Now we will come to the bacillary population. This is a very important slide. I need your attention. In a given lesion of tuberculosis, we have bacteria. We told you it will be in millions. But when you look at their metabolic activity and metabolic rates, the bacteria are not similar. Some are rapidly multiplying, some multiply very slowly, some intermittently in spurts they multiply, and some remain dormant. So we have 4 different groups of bacilli, and we need drugs that should act upon all these 4 groups of bacilli. So once again, this is a necessity for us to use multi-drugs in the treatment of tuberculosis, where different drugs act upon different bacteria. Now this is a very interesting slide. As I told you earlier, you have 4 different types of bacteria. Okay. One is rapidly multiplying, extracellular. Now almost all the drugs, INH, rifampicin, streptomycin, ethambutol, act upon this population of bacteria. So you achieve a rapid kill when you use all the 4 drugs. But when it comes to slowly multiplying bacteria, group B and group C, group B is a bacteria are characterized by slowly multiplying, and also they multiply intermittently in spurts. So the only drug that acts upon this group is rifampicin. If you take the third group, once again a slowly multiplying bacteria, these are found in acid environment, and the only drug that can act upon this group is pyrazinamide. Yet another group is dormant bacilli. As of now, we have no clue about which drugs act upon this. Usually they remain dormant for 20 to 30 years, and they may come with relapses after 30-40 years. Now let us go back to A, B and C. When you use a regimen containing INH rifampicin and pyrazinamide, they attack all the 3 groups of organisms and you achieve a rapid bacterial kill. Now what happens when this B and C, they may remain for some time and they are known as persisters, and you need drugs for longer duration in order to reduce relapses. So a regimen should achieve rapid kill by using these drugs. A regimen should also use these 2 drugs to remove the persisters and to reduce relapses. So in order to achieve cure, in order to reduce relapses, you need to include all these 3 groups of drugs. Coming to the environmental factors, some drugs are unable to penetrate into all tissues, membranes, some are not able to penetrate blood-brain barrier, so you have to choose drugs accordingly. Coming to the pharmacological basis of treatment, as we have already discussed earlier, it is important to achieve peak serum levels of all drugs simultaneously, so that maximum bactericidal effect is obtained while treating the patient. This is achieved by administering all the drugs at the same time. Do not split INH into morning 100 mg, afternoon 100 and evening 100. Please give INH as a 300 mg single dose along with the other drugs. Now, so let us look into the short course chemotherapy, based on what we discussed so far. We use rifampicin, INH, ethambutol, pyrazinamide for short course chemotherapeutic regimens, and that has become the standard of care for TB treatment in the last 30 years. Now this group of drugs exhibit 3 important activities: 1, early bactericidal; 2, sterilizing activity; and 3, ability to prevent emergence of drug resistance. Now early bactericidal activity of a regimen provides early kill, and patient becomes non-infectious, and smear and culture become negative in more than 90% within 2 months. So each regimen should have drugs that has got bactericidal activity. Sterilizing activity of a regimen determines the total duration of treatment. This slide tells you the different types of activity: early bactericidal activity, sterilizing activity, and prevention of emergence of drug resistance. An ideal drug should have all the 3 activities. Look at isoniazid, look at rifampicin and pyrazinamide. These 3 drugs have all the 3 activities in various proportions, and when you use these 3 drugs in a regimen, we achieve both early bactericidal activity and sterilizing activity. To a certain extent, streptomycin is useful in early bactericidal activity. So, it is given for 15 days or 1 month in the beginning of the treatment, and ethambutol helps in reducing the emergence of drug resistance. So, based on all these activities, we design treatment regimens. What is a regimen? A regimen is a group of drugs given in a particular combination, in a particular dosage, for a particular duration. So, each regimen will have 2 phases, namely intensive phase and continuation phase. Intensive phase will have 4 drugs, namely INH, rifampicin, ethambutol, pyazanamide for 2 months, and continuation phase will be for 4 months, including INH, rifampicin and ethambutol. Why should we have intensive phase? Now, this clearly tells you why we should combine 4 drugs in the intensive phase of treatment. Intensive phase is to achieve rapid kill of rapidly multiplying bacillary population, metabolically active, rapidly multiplying bacteria which form the majority of the population are killed in this phase. This phase also eliminates naturally occurring drug resistant mutants. This phase also helps to prevent further emergence of DR mutants, and the optimum duration will be for 2 months, and usually we achieve a smear and culture conversion of 90% at the end of intensive phase. Now, this slide tells you about the continuation phase. This is a phase of sterilizing activity. As I told you earlier, at the end of 2 months, we achieve culture negativity in 80 to 90% of the patients, and to consolidate the culture conversion, you treat them for 4 more months so that they do not develop resistance or do not come back with smear positivity. How this sterilizing activity is achieved? It is by giving drugs for 4 more months. Here you give fewer drugs, but for a longer duration. Optimum duration would be for 4 months. Thus, totally in a regimen, you will have intensive phase and continuation phase and total period of 2 plus 4, 6 months of treatment. Now, sterilizing activity of a regimen is reflected by the relapse rates after you treat the patient after they are cured. In the earlier years, we used to give treatment intermittently, that is thrice weekly or twice weekly. How is it possible to give 4 drugs thrice weekly? What is the scientific basis for this? If you look at this culture media, look at the log count. In the culture, the bacterial count goes up. Suppose this culture is exposed to INH and the culture media shows a drop in the bacterial count. Even after removal of the drug, say INH, you expect after removal of the drug, the culture media should show increase in the viable counts like this, but what you find is a continuation of the drop in the bacterial count, and this is called lag phase. Even after removal of the drug, the bacteria do not multiply. This may be for few hours or few days, and after that the bacteria starts multiplying once again. This principle of lag phase, that is, once the culture is exposed to a drug, the bacterial count goes down. Even after removal of the drug, the bacterial count continues to go down. It takes some time for it to recover metabolically and to multiply. This principle is used in intermittent chemotherapy. Now, using this principle of lag phase, intermittent doses were given maybe thrice weekly or twice weekly. The main principle here is intermittent dosing increases the efficacy of the treatment by allowing the organisms to re-enter the active metabolic phase, in which the bactericidal drugs are more effective. Currently, WHO and National TB Control Program of India recommends daily anti-TB treatment. This is based on the systematic review and meta-analysis, where they have observed higher rates of resistance when intermittent regimens were used. Also, among patients harboring INH resistant organisms, the rates of failure was more and also acquired resistance was more. So, currently the National TB Control Program of India recommends daily anti-TB treatment. It is not enough if we design a proper regimen and a proper dosage and start treatment. It's equally important that we ensure treatment adherence and see that the patient is treatment compliant and completes the envisaged chemotherapy. And for this, one of the methods used is directly observed treatment, where patient is helped by either a community worker or a person from their own house to complete the treatment. Long-term self-administration of drugs is always problematic, and patients may not complete treatment because they are symptomatically better invariably after the intensive phase, and they do not find the need to take treatment completely. So, directly observed treatment helps to reduce loss to treatment from the program point of view, and it may ensure adherence to prescribed chemotherapy. To conclude my talk, I would like to tell these key messages. 1. TB treatment regimens are designed to achieve cure and to reduce relapses. TB treatment reduces mortality and morbidity. The dictum is never ever give a single anti-TB drug or never add a single drug to a failing regimen. Always a combination of drugs should be given that act on different bacillary population that was described to you earlier. The regimen prescribed should have bactericidal activity, sterilizing activity, and ability to prevent emergence of resistant mutants. Apart from all this, it is equally important to see that the patients complete their treatment, adhere to the treatment, and do not stop treatment halfway through. This has to be done by someone in the family or from the community. Thank you for patient listening, and I hope you have understood the principles of chemotherapy. Thank you.